Hi friends, I'm Dr. Tara from AS Institute of Dentistry and today my topic is dental radiography. So let us see the definition. As per the definition, radiograph, record of an image produced by transmission of X-rays through an object. Here the object is our concerned area, tooth. Okay, from if you're getting the image of tooth with the rays of X-rays, then that is called as radiograph. Radiography techniques involved in producing various radiographic images. So here it can be extraoral technique or intraoral technique. Radiology interpretation of radiographic image. That can be small IOPA films or big OPG, whatever it may be. When we are giving any diagnosis or any treatment plan and interpreting it, that study is called as radiology. What are these X-rays? A form of electromagnetic radiations similar to visible light but of shorter wavelength. That can be X-rays, gamma rays, radio rays and visible light. All are electromagnetic waves. Why do we need this radiograph? Definitely for case selection. Okay, which tooth has to go for RCT? Which tooth has to go for extraction? We can properly decide diagnosis and treatment planning. Okay, and proper treatment. Like during our endodontic, how is our apex and all this correlation we can do with a radiograph and review. If we have done any cases with an abscess and we can see after 6 months how it has progressed or how the lesion has subsided, all these things we can have a review. So that's the reason we need to have these radiographs. Let us see armamentarium of these radiographs. Basically, all this contain a film. So the films are different size. Like here you can see the size 0, size 1, size 2, size 3 and size 4. Based upon the things, there are different sizes. Here again, based upon the speed, it has been divided into A, B, C, D, E speeds. E speed is an extra like speed. So these are the better ways. Why? Because we don't want much radiation. That's the reason we usually prefer with super speed E. Okay, how this X-ray film appears. If you see from the front, it has a raised dot. Okay, that size has to be the occlusal plane. Okay, once we open it, after the radiation has been done, once we open it, then we'll have a black cover that is called as inner paper. Between the inner paper, we'll have a dental film. Okay, this is the dental film. We have to hold with the holder and we have to do the processing in a developer wash fixer. Okay, here we have a lead foil where it stops the radiation. So whatever, so exposure should be on this side. Okay, here it has a lead foil. So we should not place this at the exposing side. This area has to be placed at the exposing side. Okay, so when the tooth got exposed and it will form an image on this dental film. Okay, and this stops the radiation. So in nutshell, we have outer package and the black one is the inner package. In between we have the dental film. Okay, and this is the lead foil. So opposite side towards tube. So what we all see when we take an X-ray, we see the dentin. Okay, we see the pulp, we see the root canal, we see the cementum, we see the enamel. All these structures we see. So how this dental X-ray unit is? It can be a wall mount where there is it doesn't. This is a floor mount where it has a stand. So if we have a floor mount, it is easy to move from one room to another room. If it is a wall mount, we can't move the X-ray unit. So it has to be placed here only. And we have another thing called as roof mount where the base is mounted to the roof. So the roof mount and the wall mount cannot be moved, whereas the floor mount can be moved from one room to the another room. So based upon your need, your convenience, you can purchase any one. So these are the film holders. This the ring shows that it has to be directed towards the cone, and this is the area where we place the film. Okay, and these are for the different positions. That's the reason it has been given the color coded. Okay, these are the film holders where we have to hold here and place into the mouth. So dark room. So everyone like giving in dark room in our clinic, it is a space consuming. So that's the reason they have this developer box. We call it as a chair set dark room. Okay. So how do we arrange this? So everyone has their own method of arrangement, but the standard method is that first we have two bottles. One is developer and the other is a fixer. Okay. In between we have to place the water. So how we have to place? Usually in our premises So here it will be written as a D. D means developer, and W means water, and F means fixer. So you have here inside you'll be having a three bottles. Okay, first you inside only you have to open the film and hold it to the pin. Okay, then from the top you can see and dip into the first developer and wait for 10 seconds. So it usually depends upon the mixing. Okay, mixing and the quality of your developer and mixer which you are using. If it is a fresh mix, then usually 10 seconds is sufficient. Then once it is done, then remove it, and inside you'll be having a red light. From that you can see the image. If you are able to see the proper image, that means it has been developed. Once it is developed, then you have to wash in the water. If you see that there is not yet completely developed, and you can dip it again in the developer for 1 or 2 seconds and additional seconds and remove. Then again wash. Then once it is washed, then keep into the fixer. Again wait for 10 seconds so that it will get totally fixed. Okay, once if the fixing has been done, again you have to wash. Then now you can get the film outside and you can see the film and read it. These are the lead aprons. Okay, everyone has to wear the lead aprons for our protection. These are the latest X-ray viewer. This is the digital viewer where the power has been supplied. Then the back side you'll be having a white light. With that you can see the things. These are the again different plates where with the lights. If you switch on, the light will come and the radiographic image will be clear. So types of dental radiograph. Just now we have seen we have two types. One is intraoral radiograph, one is extraoral radiograph. In intraoral radiograph, all the films have been placed in the mouth. Okay, in extraoral radiograph, it has been placed outside. Okay, that's the main difference. Again, in intraoral, we have BITEWING, occlusion, and periapical. Let us know in details about it. Bite wing radiograph. As its name says, the patient has to bite on the surface of the film holder, not on the film. Indications. Routine diagnosed radiograph at regular dental checkup. This is the best way to for the proximal caries. Monitoring of progression of caries, overhang restoration, diagnosis of the periodontal diseases. Okay, well, how is the procedure of this? Just now we have seen this film holder. Okay, so you have to apply like this. You have to place it, and as the on this red plate, patient has to bite on this red plate and focus the radiation. Then you'll get the bite wing. In bite wing, we'll be seeing the upper. I'll show this picture once again. See, we can see the upper teeth and the lower teeth. Especially these are best for the proximal caries diagnosis. Periapical radiographs. Periapical radiographs. Image of the whole length of the tooth and surrounding. Allow comparison between the pre and post-op condition to undertake procedures as swiftly as possible as minimizing patient discomfort. So this is an periapical radiograph. Oh, these are the multiple periapical radiographs with few bite wings. Okay, here this is an endodontic radiograph. So usually when we are doing our root canal treatment or endodontic treatment, we'll be placing this rubber dam. Okay, so how to take this endodontic radiograph? You have to release the I think you all know this is the frame, this is the rubber dam sheet. Remove the sheet from the frame, move towards one side and place with the holder and radiograph and place the angulation and take the radiograph. In our endodontic radiograph, we are mostly interested in our apex. Okay, we need our magnifications of the apex very. So whatever information we need, that should be in the center of your film. Since I need the apex and this is the center of the film. So if I need the diagnostic and this area should be the center. If the endodontic X-ray, then this should be the center. That's the difference between the diagnostic X-ray and our endodontic X-ray. Technique. So parallel film technique or parallel technique, bisecting angle technique and slop technique. Let us see in details. Parallel cone technique. Film should be placed in a mouth parallel to the long axis of the tooth being examined. If we need this tooth for the radiograph, it should be placed parallel. How we can place parallel? Only with the film holders. Center ray of X-ray beam is directly perpendicular to the film and the long axis of the tooth. The film holder must be used to keep the film parallel to the tooth. Just now we have discussed. So if this is the long axis of the tooth and this is the parallel, and from here the cone radiation has been exposed. Advantages of this is more accurate, simple, and duplication is easy. Disadvantage, film placement. Like requires film holder for the placing the film, which is difficult to place in children's and small mouth patients. Okay, and discomfort and patients like positioning of the film packet can be uncomfortable. See here, this is an like this. On this part, the patient has to bite in the BITEWING X-ray. Again, this is the way to place the film. See here, the holder is at the back, the film is in the front, and this is the way. Periapical radiograph. Just now we have discussed if the radiation, if the film is very close to the tooth, okay, it is here, see, it's a parallel, then this is a parallel cone technique. If it is very close, then we prefer to take the bisecting angle technique. So in the bisecting angle technique, patient has to hold the film or the dentist has to hold the film. Either way is acceptable. But if dentists are holding the film, then we have to wear the lead apron. These are the different radiographs. In a full mouth radiograph, we need upper anterior, premolar and molars. So just now we have discussed in the bisecting angle technique, the film has to be placed very close to the tooth, and the center of this, the angle which is bisecting the long ends of the tooth and the film, the cone is parallel to that. That's the reason it's called as bisecting angle technique. Also called as short cone technique. Film placed close to the tooth. Just now we have seen. Angle formed between the tooth and the film is bisecting. The tube head directly at the right angle to the bisecting angle. See. Okay. This is the bisecting angle. Okay. The tube is parallel to the bisecting angle. How we can achieve this? We can achieve this by giving the angulation to the head. By this way only we can achieve this. So they have given some values for this one. For the incisors they have given as a values plus 40. What do you mean by plus? Plus means the cone is directed downwards and the angle is called as 40. For the canines, since the canine root is very long, they have given as plus 45. For premolars plus 30 degrees and for the molars it is plus 20. Once it comes to the mandible, it is into the minus. Negative 15 degrees, negative 20, negative 10 and negative 5. Okay, here they are showing if the angle, if it is facing in this direction, like the head is facing downwards, then it is called as positive. When the head is at the lower end and showing upwards, then it is called as negative. Okay, just follow this picture. See, if the cone is directed downwards, that means it is plus. So for the upper front tooth, it has to be placed towards the tip of the nose. The tip of the nose should be covered. This is again an endodontic X-ray. Again for premolars, the chin, this area has to be covered. For the lower, it has to be placed from the down. Okay, for the lower canine from the lower side, like this area. We should follow the ramus of the mandible and keep the directions. So if the angle and the film are in a parallel to the long edges of the tooth, then there is no overlapping. If you have moved towards little bit of 20-degree or like that angulation, there is a possibility of getting overlapping. So advantages of this technique can be used without film holder. A patient can hold the film and it requires very less time. Disadvantages: image distortion or magnification is usually common. Technique sensitive, retakes are more, not reproducible. Superimposition of zygomatic buttress over upper molar is usually seen. Slop technique. This is very, very much important for our endodontic, especially when we are doing the mandibular lower RCs, because one root has two canals. That is the mesial root. So to identify the mesobuccal and mesolingual canal, we should use the technique called as slop technique. Okay, same lingual opposite buccal. This is the technique, and it is usually, as just now we have discussed, mandibular molar RCs. Okay, and retained roots, unerupted tooth, and foreign bodies. These are the indications for the slop technique. Okay, now how does this works? Cone shift technique or the mesial shift. These are the other names. Clark's shift, buccal object rule, reveals the third dimension. All these are the other names. So if this is the thing, if you are placing very parallel to the longer arch of the mandible, then you will have in one root two canals. So they got overlapped. Here what we are doing, just we are moving 20 degrees towards the mesial. In that way we are getting the four canals. You have seen this picture. So in one root two canals, in other root there is other two canals. So this technique is called as slop technique. How to perform? So this is the same thing which we are showing on the skeleton. So here the film has been placed and the cone has been directed. So that got overlapped and it's appearing as a two canals. And to this angle there is a 20-degree mesial shift that has separated the mesial buccal canal and mesolingual canal. In this way we can see the four canals. Then this technique is called as slop technique. The resulting radiograph shows as Lingual objects that moved in same direction as the cone, and the buccal objects are moved in opposite direction. So lingual canals are moved in same direction. Errors. Incorrect vertical angulation. So if the angulation is more, there will be a shortening. Just it's an opposite. Angulation more, shortening. If the angulation is less, elongation. Incorrect horizontal angulation. Just now we have seen. If the horizontal angulation is not correct, there is a possibility of getting the overlapping. Okay, only for the slope technique we have to give the horizontal angulation of 20 degrees. Otherwise, usually we don't prefer the horizontal angulation. See here, we are getting the overlappings. Occlusal radiograph. This is the third intraoral radiographs. One just now we have discussed two. This is the third one. Occlusal radiographs detecting the presence of the unerupted teeth, supernumeraries and odontomes. This is the main reason for our occlusal radiograph. Determining the buccolingual relationship of objects, evaluation of the size and extent of the lesion such as cysts and tumors, assessment of fractures of the jaw. Here we use the 4-number size of IOPA film. Okay, for the maxilla, the patient has to hold the film and it has been directed more than 45-degree angulation. It's almost 70 like that. In that angulation, you have to keep the cone. Then will get the film. The complete maxillary arch will be getting. For the lower, the X-ray radiation has to be placed towards the mandible. The lid should be placed towards the maxilla when we are placing our film. Okay, and we have to make the patient in a supine position. Then we have to place an X-ray cone. Then you'll get the mandible. Upper oblique occlusion. Here in an oblique way. When we are interested for the only one area, maybe right side or left side, then we use this oblique technique. Next, occlusion, upper standard or anterior occlusion, where here we consider only and our raised dot should be over the right side. Okay, we consider the upper anteriors usually more.